Most personal injury cases don't fail because of the law. They fail because of poor medical documentation. On today's episode of Injuries and Evidence, Dr. Brandon Carter and I discuss how medical documentation and treatment decisions affect case value, how medical coordination between medical providers can cause gaps in care, how lack of coordination between providers hurts patients, and how PI Sciences is fixing this problem. So join us on this episode, and thanks for tuning in. Welcome to Injuries and Evidence, the podcast where real-life injuries meet real-life sciences and solutions. I'm your host, Ted Lasso, and I have in the studio with me Dr. Brandon Carter, a.k.a. What is it? Mr. Rogers.
Mr. Rogers?
With a beard.
I was going to say, I don't know if Mr. Rogers ever grown a beard, but that's true. I need like a nice cardigan sweater. That'd be sweet.
Well, you got one.
Well, this is not a cardigan.
You can tell how much I dedicate my time to fashion.
That's all right.
Well,
you do look like Ted Lasso. I think you need to dye the mustache a little darker.
Yeah.
Do it for Halloween.
Well, I'm Vernon Dursley from Harry Potter. I'm the grumpy.
Oh, that's right. You did say that.
I'm the grumpy Uncle Vernon.
That's cool.
My son's Harry Potter. My daughter is Ginny Weasley, and my wife Rachel is she's Petunia, and then my son Micah, my littlest, he's Draco Malfoy.
Okay.
So
man,
he's even
a lot of names.
So he started saying this past week we were watching Harry Potter, and he just started going Potter.
Really?
And we're like, oh, that's perfect.
That's cool.
He's even got like the spite in that P where it's like Potter.
That's cool. I like it. Well, you guys are gonna have fun.
And maybe next year I'll do Ted Lasso. I'll have to work on my southern accent just a little bit. Well, Tennessee accent.
Yeah, I still haven't come up with an idea for Halloween. You're going to have to help me out on that one. Maybe I should do Mr. Rogers with a beard.
Moses. Just make some stone tablets.
Like 2 tablets.
And break them.
Put them on my back. Carry them like a backpack.
And you could have your 2 boys with a golden calf.
You know, that reminds me. That'd be funny, huh? That actually would be clever. So when May comes around here, because right now we're at the end of October, we're going to run the Beta Breakers. And you always dress up or something, for it.
Yeah.
And there are some pretty bad things there. I should dress up as Moses and put the 10 Commandments on my back. Like for all the runners running up behind, because half the people are naked or half the people are doing things that are just very bad. So it would be funny to throw the commandments in their face in San Francisco,
really
up the streets of SFO. Oh my gosh. So anyways, yeah, we're going to make that happen though. It'll come up in May. It's going to be a good run too.
Yeah. You've done that, 2 years? Or 1 year?
I've done it for a couple years.
Years.
I think 3 years now.
Okay.
You've done 3.
Yeah.
Well, 3 times now. So it is a good race. I mean, it reminds you that you are mortal.
Yeah.
And then they have the mile-high hill that you got to climb. Oh, man. Kicks your butt big time. And then 1 year I was there with my son Logan, and then he said, and he's running that hill backwards going, "Come on, Dad. Come on,
you
Dad.
You can do it."
And I'm like, oh, my gosh, man. Punk. I think actually he had a PR with that one. So he ran it in, so it's that one is 12K. And I think he ran it in 140 or 138 or something like that.
Wow.
Where my time's around 2. I think my PR with that race is 217. So it's a hard race. Man, it tears you up.
Rocks ya.
I think that's what it was. Yeah, he did great.
Well,
yeah, Halloween sounds fun.
Yeah.
I'm excited.
It's my kid's favorite
Send
holiday.
some pictures.
Yeah, definitely will. Well, I'm excited that you're on the podcast today, and I'm excited to talk about what we've been working on. It's been, I don't know, a little bit of blood, sweat, frustration, tears, but we're finally moving forward with it, and that is Fractional Chief Medical Officer and what that looks like, and where did it come from? Like, what was kind of its genesis?
Yeah, when we rewind back with PI Sciences, it was our opportunity to help any law firm. I don't care if you're a defense guy or a plaintiff guy, to understand the medical treatment process after a car crash, right? And that treatment plan was that black hole to where every law firm was, they're struggling with it. They're like, why are they playing doctor, and why don't we have a company that actually helps along that entire process to help them reach maximum medical improvement faster? And let's speed that up, help them out. And I think insurance companies appreciate that. I think defense and plaintiff side will appreciate it as well. And they have, and that's really what we've done. We've had great medical managers that will help with the follow-up with the patient and make sure they're jumping through the appropriate hoops to get the right treatment that they need. And we provide, the patients need that kind of support, and they need that kind of help along the way. And usually it's, most often we have seen, it's the paralegal trying to hold their hand. And a lot of paralegals are running 60 to 100 cases, and they're booked and, week after week after week. And it's hard for them to kind of keep up with that medical treatment process. I mean, constantly. And that's where we come in, right? And it's like we fill that hole, that gap, so in care. And we've had some amazing medical managers. They're so knowledgeable in the trauma world and medical treatment side, and very passionate about what we do. And we have just such a great team. And the more we've grown and expanded with other practitioners, then we started tapping into, well, why don't we have a practitioner for a law firm? And that's what a fractional chief medical officer is.
Yeah. One of the, I don't want to say misconceptions, but a common thread that I hear from both paralegals and attorneys is, well, my client will just treat what they treat, and once they get done, we'll pick it up from there. What problems do you see with that, or what kind of pros and cons can you see from that?
Yeah, so as a practitioner, I have seen it, with exam, like, again, and we rewind, right? Like, we were having attorneys asking, hey, will you do an impairment evaluation on our patient? Then we get the patient in, I'll do the evaluation, and then find out the patient has not reached, and based on AMA guides, everybody, in the insurance industry, and I've talked to so many guys in the legal world that say, they're not too concerned about maximum medical improvement and impairment ratings. And when I think that's probably the most important thing, is that we actually take a patient through that process of treatment, get them to maximum medical improvement, and then provide that impairment evaluation for them. And I think that's where, that's where the paralegals fall into a serious problem, is they'll push the patient away, right? And say, in a sense, they don't push them away, because we have some amazing paralegals out there, so that we know. And I've worked with hundreds of paralegals over all these years in the personal injury world. And there's so many amazing paralegals out there. A lot of them just don't know of the latest and greatest, though, for treatment, for medical treatment, for injuries. And in the medical world, we are always learning more new things, right? There's new stuff coming out. And right now I keep having people asking me about stem cell injections, and what about that type of treatment for the patients, and what research do we have on it? And that is our job. That's what we need to present for the paralegals. And then when the paralegal refers a patient over to us and asks questions, then that patient is so grateful that they have a direction. Kind of like all of a sudden now it's like, okay, I've done the exam. This is where you're at. This is what treatment you've had. And most of the patients have only maybe physical therapy or chiro care. There's cases right now that I've been working on that the patients are actually, they've had no care, and it's been 2 months out. And there's a lot of those cases that we see. And, really that's our job. That's where we come in as a practitioner and say, hey, this is the direction we're going to take you. And we actually give that kind of that map, that outline to the paralegal. And the paralegal is so appreciative of that. Like, they are, when I get on the phone with a paralegal just to have consult with them, they're so excited. They're like, oh my gosh, I didn't even think about going down that road. That is such a good point. They have just minimal experience on it. Some paralegals are only working 6 weeks into the firm, so they don't know really anything about active rehab. They don't know anything about disc herniation or a ligament laxity, ligament damage. What do they do? What direction do they take the patient?
Quick note, we don't make $1 from this podcast. No sponsors, no ads, just real conversations about personal injury. The only way it grows is when listeners like you share it. If this episode helped you, send it to someone else that would learn from it. Now, back to the show.
And I think that's the biggest struggle with each paralegal is the medical terminology. They'll receive they get the medical records at some point, in the process. Or they talk to the client and the client says, hey, I had an exam with my general practitioner. They said I need maybe pain management, like a steroid injection. And then they just say, okay, go ahead and do it. And that's really, and again, they're trying to work with them, but they just say, find your own path, find your own direction. So
the other side, I know that a lot of law firms have business relationships with various clinicians because it's a referral base for them. So qualified, very high quality referrals come from medical providers. But one thing that both you and I have noticed is we've seen a lot of medical documentation. One, there's a lot of providers out there, and law firms kind of have this very small impact business network. Rightfully so. Like you can't business develop 10,000 providers. Like it's physically not possible. So how do you curate the best of the best to work on your cases? Where you trust their clinical diagnosis, their treatment plans, their outcomes, their documentation that support your cases in a way that you understand.
Yeah, I think a lot of the attorneys, again, that goes back to credential, right?
Yeah.
And it's like, hey, I'm going to look at, again, yesterday there was a neurologist, I'm looking at, he's a DO, but he also has a master's in public health and master's in science with, I think it was health administration. It's kind of interesting, looking at his credential. But that's amazing for, like, again, in personal injury, we always say begin with the end in mind. And, you always got to think that deposition, that trial, what an amazing neurologist to have, in a deposition or in that trial, experience in front of a jury. And, I think that's what the attorneys got to look at is they're going to look for credential, number one. And then ultimately they're going to have the client go over to that doctor, get the exam, and then they're going to look at that documentation.
Yeah.
And it's always that it doesn't matter. I mean, that's the only thing that an insurance company is going to receive, right, is documentation from that doctor. It's not like they're part of the examination or anything. So if it's not documented, it doesn't exist. And so if that neurologist has zero experience with explaining things to an insurance company on paper, then you lose. And that's the hard part. Because although the patient is injured and there's positive findings and, and the neurologist says, yeah, they have a concussion or that was the case dealing with yesterday. But it was, if they are experiencing mild traumatic brain injury and even the neurologist doesn't even put that down as a diagnosis, just this is our intended treatment. It sounds like they have ongoing headaches, so they put headaches as a diagnosis. Are they really taking it to the point of diagnosis and treatment plan that's appropriate for that patient?
Yeah.
And documenting it, though.
Yeah.
I think that's the biggest downfall. And any insurance company would agree with me on that. It's like, yeah, once I get the records, this is all I have. And we're going to push it forward into, we want to argue against this in negotiations, and I don't know, maybe we'll even go to court. Or at least mediation, most of them, or arbitration. That's the direction they're going to push it in. So that's where I think where PI Science is we're so passionate about that. That's what we love is like making sure that patient, that documentation is clear, it's accurate, that the physician's trained and understands. It's like you gotta, if you're gonna, it's like if I've been to Medicare training courses. It sounds so weird, but as a chiropractor, if you don't diagnose with subluxation as the first diagnosis, and then all your subsequent diagnostic codes are after that, after subluxation, if you don't have that as your primary, you don't get paid. That's the way Medicare works. It sounds so stupid. And if you're not putting in your documentation, like if it's not within the past 3 months of the injury, et cetera, then you're probably not going to get paid as a practitioner. But we need the practitioners out there. We got to keep the lights on. You got to get paid. That's super important. There's nothing greedy down that line. There's nothing. I'm passionate about my practice, and I love what I do, and I love my patients, and I want to keep these lights on. So I do need to get paid for it.
Yeah.
And I've been questioned that I don't know how many times in deposition or as an expert witness in a trial. So, Dr. Carter, how much are you getting paid for this? Well, yeah, I got it. I'm taking 4 hours out of my day right now. I'm not seeing patients. I got to charge something for this. I got to get paid something, right? And it's the same way with our documentation. If you're not going to do it right, you're not going to get paid.
Yeah.
And that's legit. And that is, that happens all the time. I mean, you've seen the letters we've had, even in my own exams, where it's like, ooh, I forgot to put that code, on my CPT code, or that modifier, or that's, it's like, you got to know it and you got to be trained on it.
Yeah.
Or you just build a cash practice.
Yeah. One thing I think where this makes a lot of sense for law firms is the discussion. So the discussion that needs to happen with providers if there's incorrect documentation. So we've had a lot of cases where, let's say the patient was referred in for a total hip replacement as a result of a T-bone accident. And there was degenerative arthritis in the joint. However, the reason it was asymptomatic prior to the accident. And he was hit in what I think was a labrum tear, or it was a labrum tear, but the orthopedic surgeon that was on that surgery.
It was a complete
there was like multiple surgeons are like, we can't do the labrum tear because of the degeneration, so we need to do a full hip replacement. But in the documentation, it just said they did the surgery as a result of degenerative arthritis, not a result of traumatic injury to the labrum.
And when that one crossed my desk, like, you just look at the top of the page, it says like reason for this visit, and it's in all capital letters. And they weren't using like 12 font size. It was like 14 or 16. It was huge. And it said degeneration. It's like,
yeah. But what I see with the fractional chief medical officer, how do you get on the phone with that orthopedic surgeon? How do you get the records amended to where it is accurate? Because that was one of the big downfalls that firm was running into. I don't think it's ever a comfortable conversation for a paralegal or any other non-medical specialist to be calling a doctor saying, hey, you documented this wrong. Let's fix it.
That's a great point. I mean, so, when a fractional chief medical officer jumps in and says, hey, I'm calling on behalf of this patient, they're a client of attorney XYZ or whatever, then it opens up that medical discussion versus a legal discussion. The attorney has, or a paralegal, especially a paralegal who's someone who's very, I know paralegals that are been doing it for 20 years in personal injury world, and they're so incredible, and they probably still would have missed that degeneration, and they're like, man, I don't remember who the paralegal was on that situation, but I think it still was a well-experienced paralegal that was involved in that, and it was that one thing. But for me to be the one saying, hey, can I speak with Dr. XYZ? And because I'm looking at the documentation here, and it looks like we're missing the diagnosis of the torn labrum.
Yeah.
And then that doctor got on the phone. He called me back that afternoon, and he's like, you know what? I see what you're talking about. I don't have torn labrum anywhere. In fact, he goes, it was my medical assistant, my MA, who typed that up, and then I just signed it, and then we sent it off. And it was a total miss. I mean, it took.
Which I just want to highlight. That's actually a very common practice in like every practice. Your CAs, your MAs, they're writing the notes for the doctors. Yep. And then doctors are just
PTA,
signing those at the end of the day.
Yeah.
Yeah.
And in all aspects, because again, when you're seeing, I've been in practices where we saw 80 to 150 a day. And if you don't have a CA sitting there just kind of helping you along the process with each patient, there's no way you can keep up with that work.
Yeah.
That's brutal, man. That's too tough. And so that was a surgical center, that they missed just that diagnosis of labral tear.
But what does a diagnostic change like that do for a case? Because I remember they were getting a lot of pushback, like $20,000. They had, I think, $500,000 available on that case, but they were only getting like $20,000. Like, didn't even cover like the medical treatment for all the conservative care.
So if we understand like the software system for insurance companies, it makes perfect sense. An insurance company, that's a pre-existing condition, right?
Yeah.
And so why would an insurance company pay for a pre-existing problem? That makes perfect sense for an insurance company to not pay for something that was a pre-existing problem. It was before the crash. That's not our problem. We don't need to write the check for that.
Yeah.
That makes total sense to me. And what we have to do is understand certain conditions like degeneration, for example. That's a very simple term, right? And then, was there any subjective complaint prior to the crash? Was the patient seeing a practitioner prior to the crash for that degeneration due to a functional loss? So, in other words, I can't really work anymore now because my left hip is rocked because of degeneration. Yeah. Or were they working? Was their life normal, in a sense, whatever normal means?
Yeah.
I mean, we could go over that term normal for hours. But when I'm thinking about it, I'm thinking of functional loss. I'm thinking, did they have functional loss prior to the crash? And then with the functional loss, was it due to degeneration prior to the crash? And if the answer is no, then we got to accept that, and that's what you call eggshell doctrine. In our state, eggshell doctrine is critical. We got to understand that, hey, they could have a degeneration problem going on. The diagnosis after the crash, though, was labral tear. And now that has to be caused most often by trauma. I would say, 95% of the time, you're going to get a tear because of a traumatic injury to the hip.
Yeah.
And now the patient's limping. Now the patient's, using a walker at times. I think that patient was a few times using some kind of a cane or crutch, to help them in our office. And then they had the surgery and they're better again. Yeah. So it's like, that's where, as an insurance company, it changed it from, $20,000, $20K offer, because then they accept, I see the labral tear. We better, if they took that into a courtroom situation, it's pretty obvious. You can just put that up on the board and, and the surgeon actually did amend their note and said, yeah, good point. I totally did not put labral tear in there. Yeah. That's the beauty of a fractional chief medical officer. That's where you're coming in and you're able to help, whatever firm or who, whatever
streamline
group of
not just the
paralegals.
Documentation review, but helping them through that process. The clients and the paralegals and case managers, like they have go-to medical resource where it's like, I can ask questions, I can figure out what's going on, I can learn, I can understand the diagnosis and what this actually means long-term for my client.
And that's exactly right. And then they have someone to reach out to, and it's consulting 24/7.
Yeah.
It's like, hey, doc, I need an opinion on a case, or I need what direction do we need to head now?
Yeah.
And it's good the way that outcome was. And I think we've seen hundreds of them through PI Sciences. I've seen so many of them even in practice, prior to PI Sciences starting. And it was just, wow, man, it seems like we're missing a few things here.
Yeah.
I mean, I remember seeing there was a patient whose knee went into the dashboard, a passenger. It was a head-on collision, and their knee went up and went into the dashboard, and it totally tore the PCL ligament in the knee. And it was like that patient had been to a few other practitioners and stuff, and the only thing that they didn't do was an orthopedic test, that you just have the patient on their back and you push down on the leg, and it was like, oh, and then the knee moved like 3 inches down like that, dude. It was like, oh. I mean, I remember my gut going, oh my gosh, that was disgusting. I almost threw up in that whole situation. It was so bad.
You can feel,
so
you
awful
can feel
for
things like crunching as it's moving.
Oh, as it just slid down, that tib fib slides down on top, under that femur, and it was like, oh, man. So have you, did your GP do that? And they were like, no. And I said, did that hurt? And they were like, yeah. I'm like, that's bad. Okay, you know what we're going to do? We're going to
You're in the wrong department. Wrong department. Let's get you to an ortho, like right now.
Man. A good thing was we had a knee brace where we braced the leg and then just said, okay, so let's send you down the road. She went in for an MRI, had the MRI evaluated, and it was a total tear of PCL. And I think it was like MCL. I think it was the medial collateral ligament was torn too. And then nobody really had even addressed that with her at all. It was like spine only that she was going into. And she had just mentioned, yeah, my knee went up into the dashboard. And that's a common injury, is when the knee goes into the dashboard.
Yeah.
You know, it's like it'll tear that PCL. So,
whew. Ouch.
That was bad. That was owie. So,
well, I'm really excited for kind of what we have coming out, and we're working with a lot of law firms right now, but we're always growing, and we're bringing on more medical fractional CMOs. So really high quality medical providers, both in the community and in other states, that can give you that critical eye. So I'm excited for like the next several months of our growth.
Dude, I am so excited as well. Like, I think imagine every law firm, defense and or plaintiff, you know, if they had a fractional CMO that they were able to afford, because again, most chief medical officers would be in the hundreds of thousands of dollars, right?
Yeah.
And through PI Sciences, we keep it very low rate, very low, minimal.
Well, you keep
and
it,
we make it very affordable.
The
for
costs
them.
are tied to the case as well, so it's
They
not
are.
like a salary,
So true.
wage, tax expense. It's directly associated to each case.
Directly associated, and I think that's the most important part, right? It's like, and then they have that consultant, they have someone to refer to, and it's going to change the world. Really will.
We're excited.
I mean, that's what because the more law firms are using the medical side for the opinion, the consulting, the diagnosis, the treatment, and they're really making sure that patient's pushing through that process in a streamlined fashion through our systems. I mean, I don't know. You couldn't ask for anything better. And I am maybe a little bit on the bias side of our product. But that's what PI Sciences is based on, and we love that. So, well, I'm super excited too.
Well, we'll keep everyone posted on kind of the growth and where this offering lands and how we're expanding across the country, really. So we've got multi-states that we're getting ready to roll out, and we're just really excited for what the future holds with PI Sciences and with how many lives we can touch. So. Our goal is 20,000 cases that we can help per year, which is a lot. Like, that's a lot.
That's a lot
on the medical coordination side.
We can make it happen.
Oh, yeah. Well, you can catch our podcast, listen to us on Apple Podcasts, Spotify, and on YouTube. And definitely reach out. If you have any questions, you can go to our website. We have a simple form. Plug in your information, and I'll be in touch, or one of my team members will. Till then, enjoy the podcast. Thanks for listening to Injuries and Evidence. If this episode added value, subscribe to PI Sciences and grab our free gift, a 60-minute training called A to Z in Personal Injury. It includes all the tools we use every day to strengthen documentation and improve case outcomes. The link is in the show notes. Use it. Don't leave value on the table. We'll see you on the next one.